P3 today, you spoke about diagnostics, schistosomiasis. Can you briefly explain some of the problems associated with the current diagnostic techniques we have for schistosomiasis and how that affects disease control?
Thank you for offering me this is an interview. Actually, the disease it's become the second importance from priority after malaria, and currently we have Kato-Katz. It's been used in Africa so much common and being published so many paper. The sensitivity of this technique is low, the threshold. So basically we have nowadays CCA test which could be applicable in the field, which is more sensitive than Kato-Katz. And also we have ELISA, but it's might be overestimated because if this children is being treated can also be positive. And we thought about TagMan can fit all these techniques together. So basically we did survey in the shorelines in high endemic settings in Lake Albert, and we screened 5 schools, 2 schools further away from the shore and 3 schools in the shorelines to see from high transmission settings to low transmission settings performs all of these techniques. What we found Kato-Katz could be applicable and acceptable in high endemic settings as well as CCA test, but when you go to elimination stage, we will have to have TagMan assay or more sensitive and specific to pick apnea-affected children.
What were the challenges you faced in using this PCR-based technology in the field?
Basically, if you use this one, you cannot use these techniques nowadays in the fields because it's poor resource settings. We have no electricity there. We have no fridge to keep the reagents cold. We have to have DNA extraction materials there, and we should keep it also in the freezers. And we have to have DNA when we extract it. We have to keep it in the freezer, in the fridge, until being performed. So this is all these techniques, or all these steps. We'll have to make it in reference lab nowadays. But in the future, I hope we'll have point of care tests like RBA, rapid RBA recombinase polymerase amplification test as a point of care of test, as we did last year with the JARD test, which could be promising tool in the future.
When you investigated at these different schools, what did your results show you in terms of prevalence of disease itself?
It's unbelievable, you know what I mean? It's just like this area being under control since 2002, all right, with MDA, and the prevalence, what we found in 2015 in same school being done in 2002 is still the prevalence same. So this is mean MDA, it doesn't make any impact, because what MDA doing is nowadays, they just treating school age children only. But if they included adults and their parents and whole communities would also do Snell's control and also do sanitation, improve lifestyles for these kids, might be getting better and the prevalence go down. This is what happens, to be honest with you. And also the other problems, the rate of reinfection. If I treat children, after 2 months will be re-affected again from the shoreline. So we have to have something instead, our source of water for this community to prevent them at least for a month from this shoreline. That's it.